The gateway to the West, Cardinal Nation. St. Louis, Missouri is home to some of the most brilliant doctors in the world. These doctors are pushing science to its limits, healing patients in new, innovative ways, and doing it at the same time as they are teaching the next generation of doctors how to save lives. Meet SLUCare neurosurgeon Richard Buchholz, who has revolutionized the way neurologists all over the world stop tremors in Parkinson's and other patients. Dr. Buchholz's invention, the Stealth Station, is now used worldwide. Dr. Chand and Dr. Schwartz complete the team that is giving patients who were unable to function back their lives. This is the science of healing.
Well, I initially began experiencing tremors when I was about 16, and I've been on medication all my life.
Steve is an example of essential tremor that started in his teens, and he reached us in 2011. He had been tried on multiple medicines, none of which worked very well.
Clothing, dressing, eating, my overall quality of life just suffered tremendously.
The tremor was huge, big amplitude, disabling. He could not write, he could not eat or drink without spilling food.
We did some research, and both Dr. Buchholz and Dr. Chand were at the top of the list for DBS surgeries, and that's what initially brought us here.
The control of the tremor was dramatic, as you can see in the videos. He had over 90% control of the tremor. He was able to write again, he was able to write his name, sign a check, he was able to eat and drink without spilling. It was life-changing for him.
When they reached that point and they thought this was the spot, they turned it on and then had me do some different drills, and my hand wasn't shaking. So it was a great experience. It was a thrill for me. Just that, it was a pinnacle time in my life. Just that split second or 10 seconds that it took for them to determine they were in the right spot. It was a thrill for me.
We were all anticipating this. The way we have this set up, as you can see in the videos, is the surgical team is on one side of the CT scanner, the neurology team is on the other side, and we had a camera set up. And there was just a gasp in the room when this patient who had severe tremor, we activated the electrode for the first time, and the tremor just simply stopped. It was just a remarkable thing. And I remember looking through the plastic shield, seeing the tremor stop, turning to my scrub nurse, and I saying, "It doesn't get much better than that." And she certainly agreed with me. It was a fantastic experience, one I would never give up for the world.
My family was probably even more thrilled than I was, because they saw how I suffered over the years. And I did it for me, but I did it for my family and friends too. And for all the people out there that have essential tremors and are afraid to maybe delve into a DBS surgery. So I'm witness that this works.
First doctor said it was just a tremor, and that's all he said. Then I went for more opinions.
Because many physicians don't understand that Parkinson's can manifest itself at an early age.
It made me feel like a victim, like I thought I was going to die, I thought everything was over, my life was over.
He has early onset. Oftentimes the disease is more rapidly progressive in that situation.
When I got in regular life, people are like, "Are you okay?" or "Are you thinking I'm coming down from alcohol withdrawals or something?" And they don't believe that I have Parkinson's because I'm so young. So it's kind of hard, especially with the age group that I would be hanging around, because they're just really critical of it. So I just go to church usually. I go to some events, but it's just embarrassing. I kind of hide out in the back or whatever.
It is an unusual disease process for a person that age. And so I can see where there may be situations in which people would misinterpret the symptomatology associated with it.
They definitely stare. If they say stuff, I guess it's more hearsay, because they'll talk about me and then they'll get back to me. Like this one girl would be like, "She doesn't have Parkinson's disease. My grandma has Parkinson's disease. That's not Parkinson's disease. They're thinking I'm on drugs or alcohol or something." Probably when I was researching options, to see how my life can get better.
Deep brain stimulation is a technique to remedy dysfunction of the brain through the insertion of electrodes deep into the brain itself and stimulate parts of the brain which may be hyper-functioning or over-functioning to decrease the symptoms associated with that process.
How do these electrodes change a patient's life? Many of these patients reach deep brain stimulation at a phase when medicines are not working anymore. And actually, it's very life-changing.
It's quite remarkable in many instances. These individuals who may have been incapacitated by their tremor or by their rigidity now can start thinking about living normal lives. They can get out and about. They can take care of themselves. They don't need to have someone there constantly with them. And in many instances, they get what we would think of their life back.
I hope the surgery will take away all of my side effects that are bad and restore my life to where it used to be. Restore me to where I can be around people and social events, want my life back.
Younger people are particularly good candidates for this procedure because this procedure really does work quite well for motor problems associated with Parkinson's disease.
Your right hand shaking today? Yeah, let's see, just hold this up a little bit.
Once we have the surgical evaluation and everything seems like it would indicate that the patient would be a candidate, we have a staged procedure that is done. The first procedure is placing the electrode into the brain. We do this with the patient awake. That way we can test the patient during the procedure.
Can we see the 3D now?
So the initial part of the deep brain stimulation surgery
0.60.
starts in the planning room.
And
No,
see?
mine's 7.6.
So we go into the room together, we pull up the patient's MRI scan, and then we plan the path into the brain. I cannot overemphasize the importance of that planning.
And most importantly, we look at the 3 midline points. There, 1, 2, and 3. Great, okay. So I'm happy with that. So now we've identified the anterior commissure, and now we have a coordinate system that the computer system has superimposed upon the brain.
We can see our path into that patient's brain virtually.
You can see that we've attached an array to the patient's head. What we're doing is tracking the patient's head now with this camera system. Now, because we can see those points on our CT scan, we can now set up a transformational matrix so that wherever we point on the patient's head, we can see that point on the preoperative images.
I feel that this whole area, which is called deep brain stimulation, is part of an area called neuromodulation, where we're actually taking the nervous system and changing its activity and changing what it does, is going to explode in terms of the next 10 to 20 years. So now you can actually see where we're looking at right now, and we want to get the circle and the dot is where we're pointed right now, and we want to put that circle precisely into the tiny circle there, which is our corridor, our surgical corridor, to get down to the nucleus in this instance. I like it. Looks good. Okay. This is the a micro drive. This actually allows us to move the electrode by literally 1/1000th of a millimeter. Dr. Chan will be driving the electrode. We'll have the electrode in the brain, and we can actually record from specific spots in the brain to put the electrode very precisely right in the nucleus where we want it to be. We can test the patient during the procedure to make certain that the electrode is in a beneficial spot. And so as you approach the area, you want to verify that that piece of tissue has functional significance for the patient. One way of doing that is to record from the electrode. The recordings are oftentimes emblematic and very distinctive when you get into the area, which is responsible for a certain behavior. There can be neurons that are tracking the tremor, etc.
We're going to start the recording from the electrode. So the electrode can be driven remotely by using this knob here. When I turn the knob, the electrode is driven very slowly into the brain, and the cable from the electrode comes into the computer. Here we are able to record the discharges from the neurons. The target neurons have a very characteristic firing rate.
So we record from the electrodes, and then finally, once we think we're in the right spot, the CT is collaborating, the guidance system has worked, then we change out the recording electrode and put in the stimulating electrode and actually do a trial stimulation.
I would like you to hold your right hand up for me.
and we want to see the tremor. Sometimes the tremor stops when we put the electrode in. So hold your right hand up for me and open your fingers. Okay. A little higher for me. Tremor already looks better. There's still a little bit of tremor.
And that's the real proof of the whole procedure. We should be able to do a trial stimulation and ameliorate those symptoms like the tremor, like we mentioned previously, to make certain we're in the right spot.
Do you feel it's still shaking or it's a little better?
I hope the surgery will take away all of my side effects that are bad and restore my life to where it used to be. Restore me to where I can be around people and social events.
The electrode was exactly on where we wanted to be in terms of our surgical planning. We got good responses from the standpoint of stimulation, etc. But it is a procedure of many details.
I really don't know who I am anymore. I got to figure it out. And then with me secluding myself from the outside world and isolating myself to the house, and the depression from some of it just kind of overtakes me. So I still don't know who I am. I'm hoping to find out more after I get this surgery. I'm hoping it will make me be who I used to be. Or not really who I used to be, but at least something better than what I am now. So
once you put the electrodes in and start the programming, which is a sequential process, usually the first programming is about a month after the implant of the electrode.
You all ready for the programming?
Mm-hmm. Definitely.
Okay. Let's do it.
Okay.
Okay. And I'm going to do a brief check of your Parkinson signs before I start the programming. Yes, I can see that your right hand is shaking. Open and close. So you see how slow that is today.
Mm-hmm.
Yeah, so we're going to try and fix that today. Can you tap your fingers like that as fast as you can again? That's very slow today, all right? So I'm going to start and you tell me if you feel anything, okay, in your right hand. Open and close. Let's go. Tap your fingers big and fast. Great, that's great. And let me feel your muscle tone. There's absolutely no stiffness. Let's have you keep your right hand in your lap and look at the tremor that you had in the morning. What do you think?
Mm-hmm. It's awesome. Because, I mean, usually I can't do what he was telling me to do, and then the next second I could. So it was pretty amazing for me to see the results after that. And it doesn't feel bad.
Finger taps. See, I've turned it off and it's coming back. So it tells me
You tricked me.
that the stimulation was working, right?
Mm-hmm.
Tap your fingers again and just see how it's all come back now.
Mm-hmm.
That's because we moved from the other electrode. So the other electrode was pretty good.
Mm-hmm.
Even at 0.5 volt, it was good, and now the symptoms are back.
Life that will be changing, I think, because usually I have to take my medicine about an hour or two before I want to put my makeup on, or even eat sometimes, or, you know, things like that. So, I mean, everyday life's going to change for me.
But I'm very encouraged by the improvement that I'm seeing today.
Me too.
Right?
Patients get better. Usually they reach a peak around the third programming, roughly about 3 to 4 months out, and they continue to get better even a year later.
It's really weird though, it's crazy. Yeah, all this is crazy.
The benefit is sustained for many years. There are many research studies that have looked into this. The benefit is sustained for 10 to 15 years in Parkinson's disease. In essential tremor, the benefit is sustained forever throughout the lifespan of the patient, and the same way in dystonia too. They may need some tweaking of this programming from time to time, but we can get them better. Their symptoms are extremely well controlled, and they are often able to return to their daily activities, and also they get a big increase in their quality of life.
I always knew I needed help. I mean, I guess my 12th birthday, we got a phone call that my grandfather had died. And just like things really kicked in heavy then. But looking back, I knew I was doing things that a normal person shouldn't be doing, probably back to like 7.
The team started operating on patients primarily with movement disorders initially, and then over time more and more research is being done to look at other indications for DBS, and that has sort of branched out into the realm of psychosurgery. And what I'm referring to there is helping for patients with things like depression, Tourette's disorder, and obsessive compulsive disorder.
My first semester in college, and there's a paragraph, just a little paragraph, and it described me about rituals and washing hands and just different things, just enough that, and it said, and you are not crazy.
Obsessive compulsive disorder is an anxiety disorder in which individuals will experience intrusive thoughts, unwanted thoughts, and that's the obsession. And they can be of different contents. So you'll hear sometimes people are very afraid of contamination. And as a product of these obsessions, individuals will develop behaviors or rituals that they perform in order to reduce that anxiety associated with those unwanted thoughts that they're having.
I had so many, it's hard to explain. I mean, the ones early on were always with counting. There were good numbers and bad numbers. Brushing my teeth a certain way has been a ritual forever, and I'd line up different toothbrushes, and very time consuming. If I messed it up, I had to start it over again. Just this feeling I had that if I didn't touch things, then something bad would happen. I would try to keep my thoughts vague, so I wasn't thinking so much as this specifically is going to happen to this person. But if it reached that point that something specific would happen to a person, that's when it caused me so much distress.
Mary is very impaired. She was a very high-functioning nurse and had been incapacitated over the years by her obsessions and the compulsions that resulted because of them. So she was just unable to function as a nurse.
It had gotten so bad that I had this one image I'd have to have, and I couldn't step on my brake until I had perfect image of this person. And he had red hair, and it had to be the right shade of red. It couldn't just be any red, it had to be perfect. And so I couldn't, in my mind, I couldn't step on my brake until I had that picture. So, I mean, I couldn't drive like that because I was going to kill somebody.
So Mary is a case of refractory obsessive compulsive disorder. She's had it for many years. She'd been tried on a different number of medicines for OCD and not doing so well. She's still on medicines. She had also been treated with what's called cognitive behavioral therapy. And she had reached a stage when the OCD was so disabling that she sought deep brain stimulation.
I think it's 4 or 5 years ago. It might have been on Dr. Phil or something like that, and they had somebody on there for it, and I thought, completely trial, and I'm like, oh my gosh, wouldn't that be something? Wouldn't it be something if I had that and it worked?
So we implanted her. She withstood that very well. And then we have started to program her.
Tell me, how do you feel right now?
I'm feeling better.
The first programming was a month after the surgery, and she's gone to 2 more programmings. She's doing extremely well. She's now able to drive on her own,
If I can drive
come out of her house. Many of her obsessions have come down. There is also long-term benefit. As the months roll by, the benefit gets better and better. We are looking at peak benefit roughly 6 months from the surgery, and that continues to improve over the next year or 2 as well.
The first programming, wow.
It was a great day. Mary came in February after she was implanted in January.
I'm feeling hopeful.
On that first day when Dr. Chan turned the generator on, it was kind of this moment. My intrusive thoughts aren't here right now. And I don't think that she had experienced that for years.
I mean, it was like, I don't know how to explain it. It was like a miracle. I mean, and I mean, I'd prayed all my life, my parents, my grandparents, my great-grandmother, I mean, prayed that, this, somehow would get better.
Picture being in a really crowded room with lots of people talking at one time. That's what it's like. All of those thoughts occurring at one time. It's hard to concentrate, it's hard to function, and those stopped.
You know, you get to be in your 50s, you kind of give up on that. You know, it hasn't happened yet.
It feels good.
Okay. And is it a happy feeling? Good.
It's hard not to cry. I mean, you get so happy that we have something that we can do that really changes the course of a life of someone that has been suffering since she was 7. I can't even imagine walking in those shoes.
Yeah, she was so amazed by the response.
And I just always set these little goals just so I would live. And it's not that I was suicidal that often. I mean, you know, I had a couple spells, but it was more like, please God, if you really love me, just take me. And now it's like, please God, let me live.
I cry when I'm happy.
You kind of have to like hide in your white coat. I'm not crying, I'm not crying. It's so rewarding.
I miss her happy tears and not sad.
You feel happier? Good.
My daughter wanted to go shopping, which we haven't done in forever. And I went with her and we spent the day together shopping, and she was telling people that she had her mom back. That it'd been 10 years since she had seen me be able to do that stuff.
Hi Steve, how are you today?
It's been great every year. I mean, I come back probably once every 6 months just to get it fine-tuned. Today I can do everything that I couldn't do before. And I will always be changed based on my surgery, for sure.
Dr. Buchholz is credited with the invention of the Stealth Station, which is actually a software designed to travel into the brain.
The story of the invention of the Stealth Station is a rather interesting one. I trained at Yale, and there we had a very active epilepsy program. And there, the earlier field of image guide was called stereotactic surgery, and it was done with a device that actually bolted to the head and looked somewhat like a medieval torture chamber. It actually had bolts that go in the head. And we would routinely use this device to place an electrode into the brain to record seizures in patients with intractable epilepsy. The idea being is that if we found the seizure focus, we could then perform surgery on that focus and ameliorate the seizures. The problem, of course, was this device that looked like something from the 1800s. It was purely mechanical. It had all sorts of knobs and vernier scales and things. And my approach to neurosurgery actually was from computers. The first time I got interested in neurosurgery was on the course on neurophysiology, which I took simply because it looked like computers, and I had been in love with computers since I was 11 or 12 years old, building computers, etc. And so I immediately said, well, there's got to be a better way. This is something from the 1800s. With modern digital technology, we should be able to computerize this and take this field, which was only at that time performed by, I'd say, 0.5% of neurosurgeons at all, because no one wanted to use this frame, and use this precision and get it through in the entirety of neurosurgery to improve neurosurgery. So I had some thoughts about how to do that. I came to St. Louis after residency. I was able to get some benefactors. The Bakewell Foundation was a benefactor. We were able to buy a stereotactic device, which I then extensively modified in my basement to use, instead of a mechanical system, to use an electronic system. If you think about a mouse, that was a 2D digitizer. I was able to use a 3D digitizer bolted on top of the stereotactic frame in order to do the localization. And so we did our first cases with the new system in 1990. Subsequently, working with Kurt Smith and Lee McDermott and other individuals here at the university, we were able to get rid of the frame entirely. That then yielded an FDA-approved device in 1996, and that was subsequently sold in Medtronic in around 1998. And now they are the purveyors of this system, which I think is probably being used on around 85 to 90% of all cranial surgeries worldwide at this point.
Dr. Buchholz is a great innovator. He has several inventions, and he has continued to innovate on what we had. If you go into the OR, His OR is like Space Lab. There's so many TV screens and gadgets, and he's always thinking of a new innovation.
The question is whether the advent of navigation has changed neurosurgery, and I would have to say 100% certainly it has. It has changed the practice of neurosurgery dramatically. Perhaps no more so than when I train my neurosurgical residents. And one of the things we take care of frequently are subdural hematomas, which are fairly large blood clots on the brain. My residents now are using the navigation on those things, which are relatively large targets, but they simply don't feel comfortable without the system telling them exactly where they're going to go into. And so literally, yes, I think navigation has changed the course of neurosurgery, and I think it's dramatically improved the way we do brain surgery.
I love my team. Dr. Chand and Dr. Buchholz are so fantastic to work for or with. We're kind of like, the Three Musketeers when it comes to this kind of stuff.
I think teams in neuroscience are absolutely critical. Again, going back to my days of this residency, we had built a team around epilepsy where we had neurologists, psychologists, and surgeons all working together. And that really impacted upon me as being the way that I wanted to practice my career. The neurosciences are such a complex field that no one can have all the knowledge of all domains. And so as a surgeon, to me, it's incredibly important that we have an individual who is an expert on the medical management of Parkinson's disease to make certain that we have not overlooked some sort of intervention that could be done in this condition. And then from a psychological standpoint, Dr. Schwartz is absolutely critical as well, because obviously as a neurosurgeon I am not particularly attuned to many of the emotional issues as well as the cognitive issues that a lot of these patients manifest. And so to me it's absolutely important to get her input and her green light to think about a patient as being a suitable candidate for deep brain stimulation.
Working with a giant like Dr. Buchholz, working with Dr. Lawrence Schwartz, extremely intelligent young neuropsychologist, it's been great.
I don't want to have ever a situation in our team where, well, that's the neurosurgeon's electrode and these are the neurologist's medications. Rather, in our team, it's everybody's medications, it's everybody's electrode, and everybody agrees before we proceed on.
SLUCare Physician Group has changed my life. I've said that many times, so I'll say it again. They've changed my life for the better, and I wouldn't go anyplace else.
Gave me hope, future, wanting to have a future, knowing I can have a future.
It really, to me, is a fulfillment of a lifelong wish. I knew what we could do with precise guidance in neurosurgery. I didn't realize how great the impact would be on these patients with Parkinson's disease and with obsessive compulsive disorder.